I am pleased to welcome you tonight to our final session in the series in the aftermath of COVID-19. With over 100,000 deaths in the UK and 400,000 deaths in the USA, we recognize that COVID-19 is still with us, alive and in epidemic and pandemic mode. We in the Bahamas are remaining vigilant with the hope that our topic remains in the affirmative. We are in the aftermath. Though we have peaked to over 8,000 reported COVID infections, our daily counts remain on the downside of the curve, just 7 cases on the 26th of January. By the following day, we had 21, but we believe that at this moment, we are in the aftermath. It's time to reflect on the challenges arising and how to overcome them. Tonight, our focus is more on the social aspects of our social determinants of health. We have 4 dynamic speakers. I'm very pleased to introduce our pediatrician tonight, Dr. McNeil, who I would say without reservation has touched and bettered the lives of more children in this country than you can ever imagine. A graduate of the old Government High School, I must beat my chest when I say that. He did his medical training at the University of the West Indies and then his postgraduate training in Detroit at Wayne State before returning home. His entire medical career is one of public service, serving as a consultant pediatrician in the PMH, also as head of the department, and also past president of the Medical Association. He pioneered the development of our neonatal ICU. Tonight, he will talk on this most important issue of balancing the act of keeping our children safe while ensuring they get the best education that we can provide. Back to school. For who, when, why, how, and where? Dr. McNeil.
Thank you, Robin, and Dr. Holliday and the UWI faculty for inviting me to give this talk. It's always a pleasure to serve, particularly with regard to the university, which we take great pride in our regional institution. So tonight, I have the opportunity to visit a topic that is extremely important. Children, as we all recognize, those of us who have children and grandchildren, are a very serious resource, national resource. And in actual fact, what we're doing is we're training them to replace ourselves and to run things. So often in the practice of pediatrics, I have to remind parents that kids are actually in transition where we are weaning them towards independence and adulthood and making decisions and making choices which would benefit us and the nation and the region down the road. So disclosures, I have none. I'm a general pediatrics. I am a stakeholder, being a parent and a grandparent, and I have an extreme interest in getting it right. So our aims and objectives, understand why schools should open, know the different ways of achieving this during the COVID-19, be aware of the roles parents, teachers, and healthcare providers, what to do about illness, vaccination, and then to take ownership and participate in the decision making of how we customize it and own it. Okay, so the COVID dashboard for the Bahamas, and basically it's meant to show and basically it's meant to show that our cases have decreased. Okay, our cases have decreased considerably, and this comes with some portion. I must say that I'm very proud of the work of the Ministry of Health and the leadership of Dr. Dal Regis and the government in making very sound decisions in regard to this. Like it was said, there's really no book on this, but the general principles that we've adhered to and the mandates that have made it um, practical to get this done have put us at a point in time where we have to open the country, open the economy. And as you know, parents, in order to go to work, have to have some place to send the kids, and that's the school. But besides that, um, school serves other function. So any of you who have had to stay at home with kids and work online with the kids running around know the problems. One, there's an issue where you're not exposed to the usual structure of a school. There's the issue of peer-to-peer competition. When we were in GHS, we had something that we called a wave. And the wave essentially was that everybody else was competitive and scoring high in exams, and you weren't going to be the one to be left behind. So you made sure that you knew your work as well. So there's the wave, there's peer review, there's the social emotional component of school, where there's the face to face learning, um, what things are socially acceptable, what things not, and so on. So school itself has its benefits, and the lockdown situation in COVID and online situation in COVID that has certain advantages too, and I'll get to that later. But for now, we need to figure out how to get back to school. So I went through some of these already and forming relationships with our peers. A lot of us still have long-term memories locked into the people we went to school with. Good. So, and this is from the American Academy of Pediatrics, and it states what they call key principles. And number one is opening the schools generally does not increase community transmission, particularly when guided by WHO, UNICEF, CDC, and other very reputable sources. School transmission mirrors but does not drive community transmission. So basically, what this is all about is that it is the level of viral transmission in the community that infects the schools. And unless there's like a super spread event, as you've seen on television in some places where they have big football sessions or wrestling matches or something like that, it's not going to be the other way around. Number two is we need to revise and update strategies to deal with our school system using data about the viral transmission in community. So if we took our data, for instance, when our viral transmission drops, that's the opportunity for us to maintain school or look at face-to-face school just as how we're doing now. And basically, we must match the goal of education with the, and that's the ideally in person to person with the practical aspects of preventing community transmission. In other words, keeping our viral numbers low. So the CDC put out something that, and they called it the indicators for dynamic school decision making, and this was or is a type of formula for deciding or guiding what to do about school opening. And what they looked at was these indices, the number of new cases per 100,000 persons in the last 14 days, the percentage of uh, real time, the PCR test positive during the last 14 days, the ability of schools to implement the 5 key mitigation strategies, consistent and correct use of masks, social distancing, hand hygiene, cleaning and disinfection, and public health support, contact tracing, quarantine, and isolation. So some comment on this. When you have small numbers for the number of new cases per 100,000 or a small population, I think you'll have to look at that very carefully. The more important figure is what's happening to your trends. What's your national trend, down or up? And you want to pick those up early. The percentage of tests that are positive depends on how many tests you're actually doing. In our region or in the Bahamas, we're doing tests on suspected cases and some contacts. So we're not a big general testing area. So our ratio, again, you'll have to look at what the trend is. Since we're consistent in how we're doing our testing, we'll have to look at those percentages and see whether they're trending up or down. Consistent and correct use of masks, we're doing a great job with that. Kids over 2 can wear a mask. And the requirements for wearing a mask are that you have to be able to take it off yourself if you're having a problem. So kids under 2 know, and some people with disabilities, the answer to mask wearing is no, and they can wear a shield. Social distancing, the recommendation is 6 feet. Hand hygiene, either with a soap and water or alcohol-based hand hygienic solution with at least 70% alcohol, cleaning and disinfection. And where I think we really excel is with public health support, contact tracing, quarantine, and isolation. So this is what this CDC thing looks like. And you see that on the left, they have those indices, and then they say lowest risk of transmission and lower, moderate, higher, and highest. And I think for most of the time, we're in the lower and possibly lowest risk, which makes school opening appropriate for us. So strategies to keep schools safe. Masks, we mentioned that, hand washing. So for the schools, it's a matter of having enough hand washing facilities. For the smaller kids, it has to be at their level, and they do need the supervision. And there are various things to help kids with washing their hands, like singing a little song while they wash their hands and stuff like that. Social distancing 6 feet. Again, some people go as low as 3. 6 feet is ideal. The question is how many people you're going to be able to get in your classroom if it's always 6 feet. Cleaning the surfaces, no sharing of pencils and things like that because of the cross contamination. Um, so the next thing about not allowing sick kids in school. Some people follow the guidelines of cough and cold and runny nose, but it's going to be appropriate to say no one who is sick should be in school. Some of the kids, the younger kids in particular, can have COVID without having fever. And as you know, 25% or more can be totally asymptomatic. So that if a kid is in school, is sick, we want the parent not to bring the kid to school. And if the teacher detects any symptoms at all, we want them to call the parents up and have them remove the kid from school. And then the next thing is primary care provider notification or hospital notification. In other words, once there's a suspected case of COVID, then we need to notify public health. And like I do, if I send a kid into hospital, I call the consultant up and make sure that they've notified public health appropriately. Otherwise, I'll do it myself. The last point is to stay at home quarantine if exposed to a known COVID case or a case where the symptoms are consistent with COVID. And what the guideline says, anyone within 6 feet of the patient for a cumulative total of 15 minutes or more in a 24-hour period, they should be quarantined for 2 weeks. Right. And how long to stay at home with non-COVID illnesses. And this may be where we're going to have a bit of confusion because once school are open, we're seeing a little more coughs, colds, runny noses. All our kids with allergic rhinitis are now symptomatic and they need treatment. Some of the asthmatics, but not too much, are acting up. And what they recommend for school is non-use of nebulizers. The inhalations with the aero chamber is preferable because the nebulizers run the risk of aerolizing the virus. So the preference for school, if needed, for an asthmatic would be an inhaler and an aero chamber. And Fortunately for those in our preventive medicine techniques, the parents can give it before school, after school, and check the peak flow and resolve things like that. But the other thing about the non-COVID illnesses is how long to keep them away from home. Are they COVID? No one's going to test them. So it might be recommended, okay, to keep them home for at least until all the symptoms have resolved, okay, and possibly for as long as 7 days without any testing. Okay, now one of the ways we can look at helping out with that is the primary care providers can bear in mind that they want to follow all of those cases of illnesses that are so-called non-COVID illnesses. So that retrospectively, they can look at those and see how they're affecting things and get the sort of research or evidence-based feedback back to public health so that we can more fine tune that issue about which illnesses we might include in the 14-day quarantine. So there are other little issues. Some people may call it bubbles, pods, but isolation units that are specifically designed for school. And some of them might be like keeping children in the same classroom with the same teacher as much as possible. Certainly this is going to work for the younger ones. Just same classroom, same teacher, and they function as a group. Um, what the schools are going to have to do though is they're going to have to look at having extra teachers, teachers who might be cross-trained to take the place of another teacher. Because just like the students, if the teacher develops a little cold, cough, sore throat, we don't want the teacher to come to school either. And we want seamlessly another teacher to be able to slip in there and conduct that class. For high schools, same classroom, but the teacher moves instead of the students. And that's to cut down on the congestions and bumping up to each other and meeting in the corridors and that sort of thing. We also need to review what we're doing with physical education, and perhaps it might be appropriate for that to be done at home. Right now, it's only once a week. So missing that once a week is not gonna make any difference to the child's health as far as I can see. We need to allow liberal time off for teachers. At the slightest suspicion of an illness, that teacher needs to be able to go home and be replaced by someone else. And parents need contingency plans to keep their kids at home when they're ill. So in other words, one of the things, discussions that the headmaster or the administrators need to have with parents right at the very start is that, okay, if your kid shows any sign of illness, they can't come to school. And so, unlike times before, we could drop the kid off or they just have a cold. No, you're gonna have to take them home. And please understand, and this is from a provider point of view, that some of these viral illnesses that the kids have, the colds and different things, are not gonna go away with just a little histol or some medicine. They're gonna take about 3 to 5 days to wind down. So your kid's gonna need to be home for 5 to 7 days, maybe, because we're gonna have to make sure that the illness is completely resolved before the kid returns to school. So what to do about the Bahamas? Okay, what is our particular individual situation? And here I bring in my opinion, okay? And you know, it's not attached to public health, it's just my personal opinion. And I think that for now, we're doing okay. And we don't need to be adventurous and bold and open school up anymore. But we do need to hold steady with what we're doing. Bear in mind with online learning, what the COVID epidemic has done is shown that a lot of teaching can be done online, a lot of meetings can be done online, and there's a potential to save a lot of money. Now, for the kids of the future, it means that a lot of things is going to be online. And kids are really great learners. The younger the kid, the more the material tends to be locked in as they learn at that young age. So that exposing them to the tools that they're going to need for their future, not ours, because our education so far has been the way it is. But this practice to deal with COVID has set a standard that's going to stay for a long time. So there's going to be a lot of online learning going on from here. And so having the kids learn that at home is not so bad. Plus, we've been very fortunate in the Bahamas to get great public support and donations for kids so that they have access to these tools. So we're probably going to get the best of both worlds. One is the online learning. Two is once schools reopen fully, the person to person and socialization and peer relationships as well. When the vaccination is available, I would like to see teachers vaccinated or offer that vaccination as early as possible. With kids, there's going to be a while before we can give the vaccination because the studies haven't been done yet. And right now, they don't know whether the vaccination is going to take an ordinary course or what you call a pro-inflammatory course, as in the hyperinflammatory syndrome that kids are susceptible to. So the tests actually have to be done. The Moderna, some of the vaccines can go, the current vaccines can go as early as 16 years, but none below that. So the Ministry of Health is not going to immunize kids right now. We have to monitor for the variant strain of COVID, which might be increasingly infective. And that means working closely with the Ministry of Health and keeping an eye on those symptoms that do not right now seem to fit in the diagnosis of COVID. So remember, kids can have respiratory symptoms, they can have GI symptoms, they can have fever, they can have no fever at all, and they can have no symptoms at all. So trying to keep the pulse on that so that public health is aware through the primary care providers of what's happening in the community, possibly before any big blow up. Hopefully that won't happen, but working closely in conjunction with our colleagues in public health can be very useful. And we're going to have to be able to pivot on the spot, be willing to make changes to the schedule in school at very short notice if there's a percentage increase in local transmission. By and large, if we hold the fort as we're doing now and work on our vaccination program, we should do well. And I'm very optimistic of that because the person chairing the committee for the vaccine distribution is none other than Dr. Dal Regis, who led the global vaccination for MMR for the WHO way back around 71, 72. So, or whenever it was, I'm not sure the exact date, but she certainly is a world leader and considered an expertise in that. So that ends my comments, and I'm happy to answer any questions. There's so many references that I couldn't get them all in, but basically it's the American Academy of Pediatrics, the Ministry of Health, the CDC, New England Journal of Medicine, and PAHO WHO. They're all sources that I use to put together this information. Thank you.
Firstly, I really want to thank you for a most practical presentation, which presented in a way whereby I think the average parent could have listened to you and gleaned some of your words of wisdom. And so with that, I would open the floor for the next few minutes. One question, Dr. McNeil, I think that is great. It just says that, is there a role for testing all or most adult workers in the school periodically once the school gets started?
So, you know, Testing is resource dependent, okay? And I think that we have learned to use our resources very wisely. Um, Testing would certainly be welcomed if we can budget for it and afford it. As you know, some of the hotels are doing that routinely with their workers, and it seems to be very good. And it would provide more information. However, I wouldn't feel so upset if we didn't have it because we've come a long way with the testing that we've done and showed that once we take care of the main things, the contact tracing, the quarantine, the isolation, hand washing, mask wearing, and things like that, we can do pretty well. So most of this is a matter of using what you have and making optimal use of it. So if we can get the test done, great. If we can't get the test done, we're going to do well anyway.
Two short questions, Dr. McNeil. I've given you 30 seconds each. One question, very interesting. Can you comment on temperature taking by the school when the child arrives?
So it's interesting. I would have thought that the CDC would have said, go ahead and take the kid's temperature. Uh, it's not a bad idea. Everybody else is doing it. The school may as well do it, but the CDC didn't say it, okay? And they said it because any illness at all, the kid cannot come to school. Temperature or no temperature, any illness at all, you can't come to school. But there's nothing wrong with it. The problem with temperature testing, if you take the temperature and it's normal, and the kid has a runny nose, someone say, oh, it's just a runny nose, you ain't got no fever, you could come to school. No, no illness in school.
Would you recommend testing kids with symptoms to facilitate returning to school before 14 days?
No, I wouldn't, okay? The test is not the most comfortable test. And sticking a swab up a kid's nose is not the greatest amount of fun. Um, and plus, the timing of the test, you have to be careful of that. So that if you are exposed, you can still get sick anywhere within that 14-day period. The problem with doing that test is that someone may think, oh, I'm negative, and I can now go to school and not pay attention to the 14-day period. So I spoke with someone at public health today, and they said they test the index case, of course. They quarantine. They don't do retesting. So I'm not in favor of testing to see if the kid could get back to school earlier.
Okay. Thank you very much, Boise. A great talk, and you can communicate later on with Dr. McNeil. Our next speaker, we felt we needed to have a physician who had the knowledge and experience of funding healthcare services. And Dr. Naat is a native of Grand Bahama who completed his medical training at the Kansas City University of Bioscience and Medicine and received his postgraduate neurology and neurological rehabilitation training at the University of Miami Miller School of Medicine, where he is currently an associate professor at the university there and the medical director of the University of Miami Sports Center and director of the concussion program. But of importance, though, Naat brings his expertise as the founder, chairman, and CEO of the JIPA Network, a global network of healthcare providers, facilities, diagnostic centers, hospitals, and ancillary service providers. Is this extensive experience in working on systems for self-funded health plans, managed care plans, insurance companies, payer systems, and provider organizations, and a founder of several technological institutions. It really has he's really involved in the delivery of healthcare services. And so I don't think we could have found a better presenter tonight to talk about funding healthcare in a pandemic. So Dr. Naat.
Well, thank you, Dr. Robertson. Thanks all the faculty and the administration of the university for giving me this opportunity. So my topic today is funding healthcare in a pandemic from the perspective of developing nations. So I want to start by first wishing everyone a happy new year. I know we've had a tough 2020 and we look forward to a better 2021. So I'll start first by talking about the bad news. One of the main objectives of this presentation was to talk about the socioeconomic impact of COVID-19 on small nations. Pulling away from healthcare a little, and when we look at the different sectors in the economy of the world, the primary sector, which we tend to look at the sector that involves raw materials like agriculture, mining, and those sectors where we are producing raw materials to make other things happen, has some pluses and minuses. But to a large degree, we've had a huge burden on food supply in the world. Initially, when the pandemic started, we had what we call panic buying. Everybody was going to the grocery store and buying up everything. And of course, because of the supply chain situations, we were running out of supplies. The second issue is that when you look at how food is produced in the world, it's done in very commercialized entity. We have moved away from our countryside agrarian economies to more sophisticated agricultural economies. And that has a significant impact on healthcare as it addresses the availability of quality food products. So we see, in terms of how the socioeconomic impact of COVID-19, there's a chance that we are going to move back to a more agrarian, countryside agricultural economy. And for various reasons. And it's funny, when I was reviewing this, it was very fascinating to see we are now going back to the future. Certainly, our countries have relied on tourism, and we have put agriculture in our economies, because one of the other issues is how do we feed our population? Food is so cheap to produce that we tend to buy most of our products overseas to supply. And of course, that affects one of the biggest issues with acquiring food from overseas. It affects our currency and our availability of foreign exchange. So this is a major driver of what's going to happen with small nations in terms of food. Why is that so important? Because that food is very important commodity as it relates to our health and our economy. Let's look at the secondary sectors. Those are the sectors in our society where we produce things, where we manufacture. In fact, the service sector fits well into that. And we rely on sectors like tourism. And with limited mobility of people, limited halting tourism, transportation and travel, the hospitality and travel industry around the world is seeing globally over 50 million jobs at risk. That's significant in any sector when you look at it worldwide. In this case, in our Caribbean nation, because we rely on the tourism industry for a good part of the economy, we see the financial sector being affected. Credit is a big factor in the success of any business or any economy in any country. Banks are now reducing people's credit lines. In fact, I will tell you an example from our practice. We had a credit line and it was reduced by 5 times, which down to 20% to what we had initially, because banks are seeing risks. Even though you have enough dollars and you're showing good books, they are all running scared. And so when you look at the developed nations in these times.
Robert, are you at school?
I think we're hearing you, Dr. Robin. Okay, so larger nations are having economic crisis themselves. And usually these larger nations are involved in helping developing nations economically, giving loans, giving grants. So there is a concern that many of these dollars may dry up. You guys are well aware of the recent mantra in the American political landscape, the Make America Great Again concept. Selfish as this may be, it has created a situation of each man for themselves. And certainly an economy like the United States, we see tremendous drop in prices. And so what's happening is smaller nations, they say when America sneezes, everyone else catches a cold. Well, certainly the Chinese are now in in the game. Tertiary sector. Doc just talked about education, and certainly social services fall into that. And that is the service and consumer side of the sector. Throughout the world, there are over 900 million learners impacted, that's students, because of COVID-19. We see this whole issue in gender gap and gender equality, women versus men in the work sector. Women are more likely to lose jobs. And so when you look at some of the jobs that women in society perform, although that's rapidly changes, more women are graduating. Most countries, developing nations, their policies towards women are not equal in the same way towards men. And we see that certainly when you look at the jobs where there are lower wages, what we call the informal sector, the sector where you don't pay a lot of taxes, those people have small businesses that are not often measured in the economy. Those areas tend to be most so affected. So 49 million people, according to the World Bank, will get into extreme poverty as a result of this situation with the COVID-19. So what I wanted to do first is to paint a picture of what we are dealing with in terms of the world economy and how that economy, this economic situation affects developing nations as the Caribbean. Caribbean is now classified not as low income, but we are now most of our nations are classified as medium income countries. And so we're right in the middle, and we don't have some of the issues that some of the low income nations would have. But certainly when it comes to issues of health and others, we fit well within the low income countries. Let's look at the Bahamas for a moment. The IDB Bank, and I guess the center, Bahamas is one of those nations. Tourism in those countries, the IDB Bank countries, make up between 34 and 48% of GDP. There is already a 75% drop in tourism in 2020. Your economy has shrunk greater than 10%, and we don't have the true numbers, and those were back in April, May timeframe. Then you had the hurricane, $3.4 billion or 27% of GDP hit. So clearly the Bahamas, with two tragic incidents occurring, the COVID-19 and a hurricane, has put your economy in a very challenging state. So when you ask the pandemic healthcare versus general emergency healthcare, there is a real issue of resource allocation. And here's the reason. Most of our countries have a single funding budget for healthcare. We don't have an emergency fund. And when you look at what we allocate from GDP, the low to medium income countries allocate between 3 and 8%, while high income countries like the United States, Canada, Europe are between 12 and 18%. And you got to look at this as a measure of total budget. What's happening with Caribbean leaders at this point? They are looking at how do we increase the allocation. And WHO is pushing many of these nations to allocate more of their budget, higher percentage towards healthcare. But here's what happened. That's at the expense of roads, education, and all other sectors of the economy when you allocate more resources to healthcare. Here's another issue. WHO did a survey of 155 countries in May and showed that 53% of those countries surveyed had some disruption in the healthcare system. Hypertension, in terms of the access to these treatment modalities. Hypertension treatment by 49%. Diabetes, I'm sorry, I changed that. Diabetes is 49%. Cancer, 42%, and 31% of cardiovascular disease. When you consider, in terms of healthcare infrastructure, focus on budgets, take diabetes alone, 9 to 14% of healthcare spending. So basically, what's happening, because governments are transferring money from the regular funding of healthcare to the emergency funding of COVID-19, we're seeing very little, reduction in the attention paid to the non-communicable diseases, which in low to medium income countries, the non-communicable disease make up about 80% of the deaths. So what lessons can we learn from what the developed nations are doing in terms of COVID-19? And the question we often ask is, are we actually doing better than them in the developing nations? Well, here's an interesting point. What we've seen is declining death rates from communicable diseases. And in terms of when you look at the reason for that is you have a larger population of the aging, then that leads to a higher incidence and prevalence of non-communicable disease because people are living longer. So what's happening in developed nations is that we are seeing a much higher death rate in developed nations because there are more elderly persons alive in developed nations. Most developing countries have a younger population, the Caribbean included. Our numbers of people older than 65 make up about 12 to 15% of the population compared to, say, the United States, 20 to 30%, other developed nations. So we have less elderly persons who are more vulnerable to the effects of COVID-19. In fact, we have better developed long-term care facilities in developed nations, offering greater opportunities for the spread of COVID-19. So for example, someone in the Caribbean may have their relatives living at home rather than in a nursing home. And as a result, we've seen higher death rates of the elderly population in the developed nations compared to the low to medium income countries. In fact, another important point is that when you look at the laws in places like the Caribbean, early on in the COVID crisis, the reason why we've had so few deaths and the spread being relatively spreading at a much lower rate, we've had more stringent control of our communities based on laws that have been passed. Compared to, say, the United States, where we pride ourselves in this concept of freedom so we can do whatever we want, like not wearing masks and not recognizing that COVID-19 is truly a pandemic. So the low to medium income countries in many ways have done better in terms of their management and control of the crisis. One issue that we still have yet to understand because of the reduced testing and availability of accurate reporting, and also the ability in some cases to have surveillance programs, some of the low to medium income countries, it's hard to determine the accuracy of death rates and also spread of these conditions. But it's rather interesting, work done by the WHO over the years in many developing nations have created some semblance of surveillance that in fact, for things like vaccinations, many of the developing nations are even doing better than first world nations. The other issue that influences these numbers are access to protective gear, treatment, and vaccines. And of course, the availability of vaccine is becoming a major geopolitical issue in terms of trade, travel, and other socioeconomic opportunities. Clearly, the vaccine availability will change a lot of policy in many nations. And we have some very controversial issues that we must deal with, like travel and others. In fact, issues relating to healthcare workers and their ability to care for patients if they are not vaccinated versus being vaccinated. So now I want to focus on the whole issue of financing and modeling when you understand the context of where we are in terms of the world's situations relating to healthcare. So any issue that affects the economy has an effect on healthcare. And what we're really concerned about is the ability to provide healthcare on a population basis, not just on an individual basis to the people who are insured or who are the more wealthy. What we've learned from COVID-19 is that it doesn't discriminate based on your race, your gender, your socioeconomic status. It does discriminate in terms of your health characteristics. So it's a true equalizer. And you are your brother's keeper in the sense that if we do not provide services to our neighbors in terms of this condition, the spread becomes uncontrolled. So we must be responsible for each other. And even though the political climate calls for many nations to look out for their own people because of the issues of travel, it's critically important in this day and age that all nations come together to solve this important crisis. And certainly, we hope that the new government in the United States will take on this posture. So the real issue in modeling healthcare financing is front and center in this crisis. And we are now looking at what we call accountability or accountable healthcare models. Models where we look at performance-based, cost accounting, quality, and outcomes. Performance-based means that we are able to measure how a system performs. And I'll talk a bit about this in a moment. Cost accounting means that we can look at each service we deliver and determine all of the resource that's required to go into that service and come up with a fixed cost and understanding where the cost is distributed. In a Caribbean economies and in a Caribbean healthcare system, we do not have cost accounting models, and therefore it's difficult to budget from year to year. And given the unpredictable nature of healthcare and the extent to which we have non-communicable disease, healthcare as an industry and as a commodity rises and falls from year to year in a way that's not sustainable and predictable. So clearly we need these models of cost accounting to be able to come up with better working healthcare system. The issue of having a healthcare system that has ups and downs, affects the rest of our economies in terms of availability of money for education, roads, and it puts a country into a state of desperation where you're always reacting to an emergency. According to the WHO, this is the result of an unstable economy. One of the things we know is that WHO utilizes, and the World Bank utilizes the amount of dollars that we spend on healthcare outside of insurance or outside of government spending. What individuals spend out of pocket expenses is a very good reflection of how stable your economy is. And in many countries, I'm sorry?
You have 5 minutes to go.
Yes, almost there. So quality outcomes is important. So what are some of the lessons that we can learn? One of the issues that we need to understand in healthcare funding is this concept of consolidation of dollars. And that's the most powerful winning strategy for Caribbean nations. Our dollars are so fragmented by geography. We work as individual islands. We don't come together as a federation so we can combine our dollars. So our buying power is tremendously reduced. Even within our countries, our healthcare provider groups are not organized, our payers are not organized, and our patients are not organized in a way to drive the economies of scales that's required. So in order to meet the challenges of our time and to reach sustainability, we need consolidated models of healthcare providers, consolidated models in the healthcare delivery system, patients, and the payers. We need centralized administration that's low cost and highly technology-based that allows for efficiency. And in terms of the newer models of healthcare, the characteristics of those models, we need creative financing models, public-private partnerships, working with philanthropic organizations and NGOs. And there are dollars available from grants and others that we could access. Good tax policies. We need alternative funding models, such as we see with employer-based funding, health savings accounts, cafeteria-type plans. Many of those are not available in our region in terms of funding healthcare on a consolidated basis. Health systems organizations, we need to have provider organizations. We need to have managed care or managed healthcare service organizations so we could reduce cost. What we have is duplicated cost across our industries. And we need more institutional corporate organization with strong individual participation. So the healthcare payment models also must change. Rather than just a pure fee for service, capitation, pay for performance, the big ones are diagnostic related groups and looking at value-based funding models. Those value-based funding models allow us to look at outcomes in relation to what we pay and our cost. So these models are more population-based, they're more system-based, and they allow us to measure costs and have these accounting models that are necessary from a cost accounting standpoint. So the other issue is the managed healthcare models, where we actually manage healthcare, we coordinate care, and we introduce these models that are sensible. On an emergency basis, we need reinsurance models, and we need to come up with emergency reserve funds that allows us to deal with these crises. The issue of budget reallocation in the healthcare delivery system. And again, many of our financial systems don't have those built-in issues to work with. The issues of how we deal with in-kind healthcare services, products, and training. I want to point out that there are now a lot of public international agencies that are looking to work with countries that have these models. As Dr. Robin will tell you, I've been working in Grenada on the healthcare systems to try and come up with a new financing model for them. And we are working with a number of these international agencies that are providing support in this regard. So developing nations must look to that. Finally, to achieve sustainability in these times of pandemic on a long-term basis, we need time to reorganize our healthcare financing and healthcare delivery systems. We have to develop the demand for more sophisticated healthcare at home in our countries versus looking to other nations to provide us some of the catastrophic care. We see a tremendous issue with exodus of healthcare workers. We need to retain more of our workers, brain drain. Training of healthcare workers. The Caribbean now produce 25% of American doctors. We need to do this with nursing and other professions. And we also need to keep some of those doctors at home in terms of providing high-powered specialties. The issue of tourism. We are now seeing in nations where there's a huge return of nationals who have traveled back to home. And that's because of growing economies. It's time that we build a better healthcare system. There are opportunities for virtual computing. And so these people that are coming home, are companies that are relocating to lower cost centers, they need good healthcare and they need good healthcare system. So if our economies are to grow in the Caribbean, we must adapt these models. So I want to give this quote in closing. Vincent Vanderpool Wallace, who was a former minister of tourism and aviation in the Bahamas, said, "A crisis is a terrible thing to waste." We must, in the Caribbean, look at healthcare as an opportunity, not just a crisis in these times. Thank you.
Thank you, Kester. That was an excellent presentation. Goodness gracious, I wish I had the whole of my NHI team here listening to that as well. But I think it really gives us an insight into the need that we actually have the responsibility and the skills and of necessity, we have to look after ourselves. We should be looking inside as opposed to outside. I will allow these sessions are being recorded. So they're going to be available for everyone to have a look at. I just got a notification from our library. They'll be available on our own website from the university on our sunshinelearner.com. So thank you very much, Kester. Very pleased that you could join us. We needed an expert to tell us about this virus, understanding its biology, its strengths and its weaknesses, and thus enable us to use its own virulence and defenses to overcome this epidemic. I am most pleased tonight to introduce you to one of our own regional grown physicians, a medical graduate of the University of the West Indies, who subsequently returned and completed a specialty training at the University of the West Indies. And then she returned home as our first fully trained and certified Bahamian medical microbiologist, right here at the Princess Margaret Hospital in the capacity as our first Bahamian consultant microbiologist. So our next speaker, Dr. Jessica Edwards, I think we couldn't find someone more appropriate to talk to us about testing in a at-risk population, what tests and how often. Dr. Edwards.
So thank you once again to the organizers for accommodating me and allowing me to make this presentation on an interesting topic, the testing in at-risk populations, what test and how often. So I will go back over my objectives. My objectives will be to look at the most effective method of testing. We will review the data regarding the various approaches and methods to population screening. I will look at some various algorithms for testing at-risk groups. And finally, we'll discuss the management of the persistently positive patient. So I thought it would be interesting to begin by giving a historical overview of the discovery of SARS-CoV-2, as it prompted a remarkable attention and interest into the infectious disease diagnostics. On the 1st of December, cases of acute respiratory illness were noted to be presenting to Chinese hospitals. On the 8th of December, 2019, the number of symptomatic cases began increasing to a frequency of 1 to 5 cases per day. By December 29th, terms such as SARS and shortness of breath began to become more commonly referenced on social media in China, and doctors as well as the hospitals began recognizing that there was something awry. They began to concede that there was a new virus that of unknown origin that was coming out of Wuhan, China. On the 31st of December, Chinese officials reported to the WHO that there was a possibility of the new virus syndrome with symptoms of pneumonia of an unknown origin. And there were 27 cases identified and 7 were of critical condition. These cases were thankfully quarantined, but not enough. On the 7th of January, after rigorous probing and testing and analyses, the Chinese announced that they had successfully identified the virus as a novel coronavirus, similar to SARS and MERS previously known, and they tentatively named it 2019 nCoV. On around the 11th and 12th, the viral genome was sequenced and the data shared with the WHO as well as the international community. So the emergence of the SARS-CoV-2 has forced clinical laboratories and test manufacturers to develop new diagnostic tests, assays in a time frame that previously would not have ever been considered feasible. So when we look at which test or effective method of testing is the most appropriate, we know that clinical laboratories generally use key principles to assess the performance of a test. The sensitivity and specificity are 2 such performance characteristics. So sensitivity is looking to answer the question, among people with the infection, how many of them will test positive for this infection? The specificity is looking to answer the question, among the people that are without the infection, how many of them will the test as negative for this infection? We also have to look at the positive predictive value, or the ability or the probability that the individual that the test detects is truly positive or truly infected. And while we won't get into the mathematical formulations, I think it's important to recognize that the performance of the test and the predictive value of the test is significantly impacted by the prevalence in a population. So if you have a very good test that has a high sensitivity and high specificity, but the prevalence is low in the population, the predictive value that that test will pick up the positive cases could be affected and it could be low. So in the example, I have a patient, let's just say a population of 1,000 persons with a high specificity and sensitivity, but if the prevalence is about 1%, the positive predictive value will be about 50%. However, if the prevalence is increased to 5%, that positive predictive value goes up significantly, up to 80%. So it is important for us to consider which tests are being introduced and the performance of the test before we can say that this is an effective and accurate test to be used. While it will be ideal to have a perfectly performing test, that is, no test is 100% sensitive and specific, the diagnostic accuracy will be considered to be one of the most important and effective methods of fighting the pandemic, managing individuals as well as public health matters. We know that a diagnostic test that is very accurate will be very important, as you cannot make a diagnosis of SARS-CoV-2 based on clinical symptoms alone. There are 2 types of diagnostic tests which are currently available. We have the molecular tests that help to identify persons with current or acute infections, and these 2 test methods are the molecular test and the antigen test. Additionally, there are serological tests, which are most effectively used for surveillance purposes to diagnose past infections. These serological tests will detect human antibodies generated in response to an infection with SARS-CoV-2. So this pictorial basically just gives us a basic understanding of the structure of the coronavirus. And so it shows a cut surface where you have a very nice white circular area that is the lipid bilayer that the virus would have acquired through its infection of other cells. And then you have these bright pink and purple looking projections that are coming off the surface. And those represent these characteristic spike proteins that are seen on the coronavirus cell structure. We also have in the center of this image some small squiggly light lines, and those would represent the RNA. But tightly woven amongst those squiggly lines are these proteins in purple. And so those are nucleoproteins that help to bind the RNA together. So antigen tests will detect the proteins of the virus, those that are inside the center of the virus, as well as those spike proteins on the surface. And the molecular test will actually identify the RNA, those squiggly lines, the nucleic material. So molecular tests are more specifically the nucleic acid amplification test are the tests used to detect the specific parts of the viral RNA. Molecular tests begin with a good quality specimen taken from the patient and usually transported to a site off from where the patient is located in an appropriate viral transport media. Once a specimen is then placed through a series of steps, we try to extract and purify the RNA. Then it's denatured and then we amplify it. The sample reactions generated are producing multiple pieces or parts of the RNA so that you will have copies being made in double time with each cycle, leading to an exponential rise in the targets usually identified by a fluorescent signal. So the thermal cycle number at which the fluorescent signal exceeds the background and thus passes the threshold for positivity is a CT value. And that's indicated on the image in the bottom right corner of the screen. So the CT value is an approximate proxy for the viral load. The lower the CT value, the higher the quantity of viral genetic material in the sample, which means you have a higher viral load. So the nucleic acid amplification test is the cornerstone of the diagnosis for SARS-CoV. Real-time PCR, which is probably the most commonly used type of test in the lab nowadays, has become a household name because of this pandemic. The test is inherently sensitive. It's able to detect very, very low levels of virus per mil, copies of the RNA per mil. But despite this high sensitivity, many of us will be very familiar with the early challenges that we found with the RT-PCR because it resulted in patients being reported as falsely negative in many occasions. And this raised concerns about the effectiveness of the clinical sensitivity of the RNA, of the RT-PCR test, because we had independent studies evaluating the performance and finding that the sensitivities were as low as 60 to 70%. However, this experience led us to investigate further, and we recognized that the inherent sensitivity was actually not the issue because it was challenged by several factors, like the timing of the sample collection. We know that if the sample was collected too early in the course of the infection, it might have yielded a negative or a false negative result. And therefore recommendations would have been made to have tests done subsequently within 24 to 48 hours. We also found that the sample type was also a factor that could have affected the accuracy. We know now that taking a nasopharyngeal swab tends to be more sensitive than taking an oropharyngeal swab. Similarly, we are going to be later on in the course of the infection, getting a sputum sample or a lower respiratory tract specimen sample might be more sensitive and yield more positive results than that from a nasopharyngeal swab. Similarly, the quality of the sample can also affect the accuracy of the test. So if you're taking a nasopharyngeal swab, and those of us that have had one, we know how unpleasant it is. And so if a patient is going to pull back or resist the sample collection, it might yield a poor quality sample, and that could give a false negative result. We also know that these types of tests are very, very specific. So if you have a patient whose sample contains influenza, for example, we know that the specificity of the test is such that the test will not detect the influenza and call it SARS-CoV-2 incorrectly. So that's another very good characteristic of the molecular test. However, as molecular tests are considered the gold standard, we do know that there are other options, and the antigen test may be an appropriate option, or at least an adjunct to RT-PCR. The World Health Organization interim guidance on antigen testing actually stated that though these rapid antigen detection tests are substantially less sensitive than the nucleic acid amplification test, they do offer the possibility of rapid, inexpensive, and early detection of the most infectious persons with COVID-19 in appropriate settings. These rapid antigen tests are easy to use, as simple in process as a home pregnancy test. The results will be available within 10 to 30 minutes, and we know that they are relatively low cost. But their major disadvantage is that they have a very low sensitivity in some instances, and that can prove to be a challenge in using this test more widely. Unlike the nucleic acid amplification tests that amplify the viral RNA, antigen tests' sensitivity are dependent on the presence of detectable levels of protein from the sample itself. As such, in order to get a positive result, the viral load must be very high. A Cochrane review done in October showed that the sensitivity ranged from about 17% to as high as 97%, with the average being around 52%. But remember, we said that the prevalence also impacts the performance of the test. So as per WHO's recommendations, we should have a test that is approximately 80% sensitive and 97% specific, and that these tests will be best used in situations where patients are symptomatic and in the early course of their infection when the viral load would be highest. So when could we use these tests? And can these tests be used in population-based screening, for example? We know that the definition, or by definition, population-based screening would be a high volume of testing for SARS-CoV-2 in individuals, irrespective of their symptoms within the population. Screening a population can be done by performing lots of these tests and aiming to identify those asymptomatic patients in the population and confirm them as having either been exposed to the virus or having an acute infection of the virus. Population screening is often referred to as mass screening or universal screening or population-based screening. And so the approach to population screening must be considered with great intent, interest, and review. The European CDC made a recommendation for screening populations based on one of the following indications. We could screen a population to rapidly decrease disease incidence in a community and thereby reduce the pressure on the human health system. We could use population-based screening to monitor a community when there are low levels of transmission, just to see that there are no particular clusters occurring in a population at a given time. As well, we can use population screening to understand the disease prevalence by age and sex, ethnicity, and in settings in order to target public health measures. So the method used to screen populations will depend on many indications for the screening, but we can detect, as I mentioned, active infection using molecular or antigen-based testing, or we can use the surveillance method to look for persons who would have been exposed. And so if we're going to use a molecular-based method, which we know to be a very sensitive method, there may be several constraints in general to using this type of test system. They're very expensive, as you know. There are challenges, including access to reagents. We have to have multiple swabs. We have to have multiple reagents to perform the PCR or other molecular tests. And we'd have to have a system that can accommodate doing large volumes of testing so as not to overburden the laboratory and healthcare system, as well as we would need to have specialized trained staff, and we obviously would need to have a rapid turnaround time to effectively make impact on the public health system. So theoretically, that test method may not be the most appropriate to use in a wide-based population study. However, if we were to look at a more practical option for identifying acute cases, the rapid diagnostic test for mass screening may be a better and more practical option. We know that it is a very easy to use test, as was mentioned, very cost effective. We can get rapid turnaround time, leading to faster isolation of people when tests are positive, and the ability of the test to be used in larger populations without a lot of expertise and expert training and skill. So this would, of course, contribute to breaking the chain of transmission sooner once an effective surveillance system is in place. The challenge, of course, would be that it is a low sensitivity test. And so that would mean that you could potentially have a lot of false negative results in the system. And the other concern, of course, would be when you have large volumes of this test being used, and even though the specificity is high, it could potentially produce a lot of false positive results. And that could diminish the confidence of the population with this test. And that would be a challenge, because we would need to support the public in order to ensure that if this test were to be used on a wider scale, that they would be able to follow and comply with the recommendations if they were found to be positive, for example. Nonetheless, these studies have been considered and are being rolled out. In fact, there have been 2 recent studies of population-based screening being launched. One is in Liverpool in the UK, and the other is the national government of the Slovak Republic began looking at using this type of screening method for their population. And while the UK campaign is still ongoing and they have been fraught with a lot of challenges, including having to resort to real-time PCR testing, the Slovakian campaign, when combined with other measures to control the outbreak, we're finding very successful outcomes with using this rapid diagnostic test. So it is a very interesting concept and should be explored on a wider scale. So the other method of population screening that should be considered, of course, would be for identification of exposure of patients. So serological tests are an effective, minimally invasive option for determining if infection were to have occurred. You simply would take blood samples randomly through the population, and this information could give the public health information regarding how extensive the infection is within the population. So I want to also look at the algorithms that would help to guide which test could be used and how it should be used. So the WHO has a recommendation for the molecular test in symptomatic patients. So for patients that meet the clinical criteria for COVID-19 as per the case definition, a nucleic acid amplification test should be done if available. If positive, then the patient is diagnosed as a confirmed case of COVID-19. If the nucleic acid amplification test or Naat is negative and the individual does not have continued clinical suspicion, then they can be labeled as negative for an acute infection with SARS-CoV-2. If there is continued clinical suspicion, however, the patient should be re-swabbed and retested, as there may have been a false negative. And if this is still negative, the WHO recommends doing additional testing, including serological investigations, having an acute and convalescent sample taken. If the patient is positive after the acute and convalescent sample show that there is a rise in their antibody levels, then the patient will be confirmed as a positive case. If not, then there's no indication for acute or recent infection. no evidence of a recent infection with the SARS-CoV-2. However, if your repeat sample by Naat is positive, the patient will be assessed as having a confirmed case of SARS-CoV-2. Now, the CDC actually made a recommendation for the antigen algorithm that I thought was interesting to share as well. So you can see that the symptomatic cases may begin with an antigen test, and that is generally the recommendation of the WHO as well. If the antigen test is positive, then the individual will be diagnosed as infected with SARS-CoV-2. However, if the antigen test is negative, the symptomatic patient should have a confirmatory Naat. If the confirmatory Naat is positive, we again would call this patient positive for SARS-CoV-2. If the Naat is negative, and if the individual had a known contact with a patient who was confirmed to be SARS-CoV-2, the person will be assessed as having no current evidence of infection. And if there is no evidence of a contact, the individual will be reported as not having SARS-CoV-2. Similarly, and as is recommended by the WHO, there are cases where an asymptomatic patient might be tested with an antigen test if they have a close contact, particularly if the prevalence of the infection is high in that population. If the patient is negative for Naat, they would be assessed as having no evidence of a current infection. However, if the patient is positive for Naat, if the patient is positive by the antigen test, then they should have a confirmatory Naat test. If it is negative by Naat, then again, we will report the patient as no evidence of an infection. However, if it is positive by Naat, then the patient will be assessed as having an infection with SARS-CoV-2. And finally, the asymptomatic person with no history of exposure, we recognize that the WHO and CDC prefer or recommend that these tests should be done in the symptomatic population, or as I said, in asymptomatic patients with a history of a contact. So the predictive value and the pre-test probability of in this particular scenario will be quite low because the prevalence is expected to be low in particular situations, and therefore the results may not be as accurate in those scenarios. And therefore, if you are going to do an antigen test in that particular scenario, the antigen test, if reported as negative, will be reported as not infected with SARS-CoV-2. However, if a patient has a positive test if the patient has a positive antigen test, then the patient will have to have a confirmatory Naat in order for the diagnosis to be made. So what is the management of the persistently positive patient? The confirmed case of COVID-19 has the potential of shedding detectable viral RNA months after they are no longer symptomatic. A published report in the journal Medicine described a clinical case of a 50-year-old man from China who had a mild symptomatic illness of COVID-19, and he was diagnosed with COVID pneumonia. He was put in isolation, and while hospitalized, he remained in isolation while he clinically recovered due to the persistent positive SARS-CoV-2 result. On day 75, post the onset of his illness, he was discharged after having 3 consecutive negative results. He was followed up at home with multiple repeat tests and found again to be positive on day 80 and further on day 92. So the question is, are these patients actually still infectious while shedding virus so long after their initial infection? Researchers have found that there has been evidence of a subgenomic RNA fragment that can tightly bind to intracellular vesicles inside the host cell, which protects the fragment from degradation. And therefore, only as the cell undergoes its natural course of life, then the subgenomic fragments will be released and subsequently detected. But they do not represent infectious whole virus. Infectivity is actually assessed indirectly by the ability of the virus to replicate in culture, in cell culture. Therefore, if the virus does not grow in cell culture, it is hypothesized that these individuals are not infectious. Also, the further from the time the patient was symptomatic, the less likely the virus will be present in the patient sample and be able to be transmitted to cause disease. Finally, we spoke of the CT value as a proxy to the viral load. Studies have not demonstrated that the virus has been cultured from specimens with CT values greater than 35. This also suggests that the viral load is too low at this time, and therefore the patient is not infectious with CT values higher than 35. So if we were to look at this timeline of SARS-CoV-2 infectivity, the time from exposure to onset of illness, which is the incubation period, is usually between 2 to 14 days, and the average is around 4 to 5 days. This chart shows the viral load and infectivity peaks around 2 days before the onset of illness to 2 days after the onset of symptoms. And patients will be most infectious before day 5. We also know that there are other symptoms we also know that after the onset of symptoms, the viral load peaks and then there's a gradual decline. So by day 10, particles are usually no longer detectable. And if they are detectable in the mild to moderate illness patients that are generally of good health, there is no evidence that the virus can be cultured from their specimens after day 10. For persons that are critically ill or severely ill, or perhaps immunocompromised, there is a less than 5% probability that the virus will be cultured from their specimens after day 15, and certainly not after day 20. So you can go up until day 90, and these persons will be labeled persistently positive because the RNA can still be detected. However, they are certainly not likely to be infectious and should be treated accordingly. There's lots of supporting data regarding the infectivity of these patients, of these samples. And these patients, a lot of the studies were done to compare or to look at the ability of these samples to grow in cell culture and to cause secondary infection rates. There has been, the first study that was identified to suggest this phenomenon was a German study that included 9 patients, middle-aged adults that had mild disease. And those samples, after being examined, none of the samples were able to have positive cultures after day 9 from the respiratory specimens, despite having very high viral loads when they first presented with their illness. The US CDC also has documentation of many research papers that show that varying disease severity, in certain cases, patients were still not able to have viral cultures be positive after 8 or 9 days of onset of illness. In Singapore, similarly, a study was done with 100 hospitalized patients, and they looked at varying illnesses as well. 20 patients were actually on oxygen, supplemental oxygen, and 12 required mechanical ventilation. And again, there was still no evidence that after 14 days, or even after the CT value was greater than 30, that they were able to culture virus from these patient specimens. So therefore, these studies support the recommendation that we are currently using to move away from the test-based strategy for the isolation and recovery and move toward the more symptom-based strategy. So if we do find patients that present that are asymptomatic, that are presenting within 3 months, do they need to be retested? So we know that if a patient has no evidence and they are symptomatic and there's no evidence of any other potential identifier for the cause of their illness, or if they do have a known exposure and their onset of illness is within a short space of time from that exposure, then we could consider retesting them. the person should be evaluated for reinfection, and they should be kept in isolation until a conclusion is made regarding whether this is a new infection or if it is shedding viral RNA. If the patient is confirmed or if the patient continues to be a suspect, we would still maintain them in the routine isolation precautions and discontinue, as would be our standard recommendation for discontinuing isolation. We also need to know that persons that are positive during their first 90 days after the onset of infection may not likely get a new infection or a reinfection, because we do expect that, as is the case with other coronaviruses, we do develop some degree of immunity. That is a natural immunity. And so we expect that these patients will be free from reinfection during that time. Recovered cases without any new symptoms during the 90 days after their illness are less likely to have new infections and more likely to present with persistent shedding during that time. And so retesting an asymptomatic patient in that period of time would pretty much be futile. And so we should not be recommending tests for those patients. So I'd like to thank you and the organizers and everyone for your time, and you've taken away something from this presentation. Thank you very much.
Excellent, Dr. Edwards. I think that was a most comprehensive overview of testing. It's the kind of a presentation whereby I'm hoping the medical students are paying attention, because these are the questions that you ask on multiple choices, etc. And I think the presentation, for the most part, was one in which the public could really understand the indications and the pros and the cons for the various tests that are available. So we have time for one question. From Dr. Benjamin says, would you recommend doing both the NAAT antigen test and the RT-PCR simultaneously on a suspected case?
So I'm not sure if it was intended for the NAT as well as RT-PCR, because they would fall under the same umbrella of molecular test. But if your question is to ask regarding the antigen test, based on the algorithm, there may be an indication to do both. So if the patient is, say, an asymptomatic contact, there may be an indication to do both the antigen test and then the real-time PCR for confirmation. But generally, because the antigen test tends to be quite sensitive, we expect that the results for a positive antigen test in a particular setting, like a symptomatic patient, should be adequate and could be used as a single test.
Great. Well, I want to thank you, Dr. Edwards, and we're going to bring on our final speaker. He needs no introduction. He's a household name with a household presence throughout the archipelago. A graduate of Johns Hopkins Medical School with his undergraduate training in general surgery, with his postgraduate training in general surgery and cardiovascular surgery at Wayne State. And when he returned home, he has been trailblazing ever since. A former head of the Department of Surgery, president of Medical Association, he's currently a member of Parliament and our most previous Minister of Health. We could not find a more suitable person to present our final topic, conspiracy and politics over science. Who to believe? Dr. Saz.
Well, thank you, Dr. Roberts, and thank you so very much for the privilege of the floor. Okay, so good evening all, and I think it's important that tonight I start with a hypothesis. And the hypothesis is, and I think this is nothing that everybody doesn't know, is that COVID-19 is a biological weapon. And it was caused by exposing flu viruses to 5G irradiation in China. And they did this using weaponized bats and other live animals, which they released into an open air market in Wuhan. These weaponized viruses were invented in a lab. It was paid for by George Soros in collusion with the CIA, who knew that if they spread it, Bill Gates would offer a treatment of injectable nanoparticles disguised as a vaccine. I hope you're with me so far.
Yes.
This vaccine takes over your DNA, and it particularly is to sterilize Black and brown people because the injected nanoparticle carries the mark of the beast. The Chinese government and the deep state in the United States, and I want you to understand that's the Democratic Party, were all a part of the plot. So tonight I'd like to ask the question, is COVID-19 real? And the answer that you will get depends on the arena in which you ask the question. Politically, certainly in different countries, COVID has been defined as questionable in some countries, including the largest partner of the Bahamas, that's the United States. It certainly has been a controversy on social media, even though governments around the world have had to respond to what has been a very real threat. As of today, more than 100 million confirmed cases of COVID-19 have been recorded around the world. And it's estimated that the true number of COVID-19 infections are probably as much as 5 times that amount. We have recorded at least 2 million deaths from COVID-19. And if you understand the fact that every day in the world, some 150,000 people die, COVID-19 has rapidly risen in terms of causes of death. Every day, some 49,000 people die from cardiovascular disease. Another 26,000 die from cancers. And this week and last week, some 15,000 people a day die from COVID-19. That makes it the number 3 cause of death in the world as of the end of January 2021. So is COVID-19 a hoax? Well, let's see if we can dissect this issue. I used to be the Minister of Health. And very early after the initial reports coming out of China and the discussion by the World Health Organization, we started to see a number of conspiracy theories and fake news and false information. So much so that Dr. Tedros, who is the Director General of the World Health Organization, defined the COVID-19, which ultimately became a pandemic, as an infodemic. And what we found as public health officials is that we spent as much time debunking false claims as we did educating people on the facts. Many people will recall the early days, and I want to deliberately dissect the story of hydroxychloroquine. Hydroxychloroquine and other treatments for COVID-19 was argued, debated, fought, discussed at the podiums around the world, on Facebook, on Twitter, on Snapchat, in the deliberations of peer-reviewed journals, and by regulatory bodies all over the world, whether you're talking about the FDA, the NICE commissions, etc. So much so that hydroxychloroquine, depending on who was talking about it, scientists, doctors, physicians did not know whether it was useful, helpful, harmful, deadly. There were a number of trials in peer review journals that were produced. The first is a recovery trial by Oxford University, comparing 1,561 patients treated with hydroxychloroquine against 3,155 persons not treated. This trial was stopped at around June of 2020 when it was shown that hydroxychloroquine was of no benefit. The world was not convinced. Another trial or another study by Cavalcanti, published in the New England Journal of Medicine, came out in July of 2020, basically demonstrated no benefit to hydroxychloroquine. This was a randomized open label study. We then had a randomized double-blind trial published in the Annals of Internal Medicine by Skipper et al. That showed no benefit. Despite this, presidents of major countries, pundits, physicians, etc., claimed that this was all rubbish and this was big pharma attempting to suppress the truth. In the Journal of Infectious Disease, there was a retrospective study produced that showed that there was a benefit to hydroxychloroquine. Suffice it to say, this story has been put to rest, but it was not without great angst and controversy. Hydroxychloroquine has now been replaced with ivermectin. And the current understanding of ivermectin, which is going through the same battle as hydroxychloroquine, the current view is that the data simply is not enough to either support the use of ivermectin or to debunk the use of ivermectin. What we have found is that Facebook, Twitter, and Instagram are as important in the adjudication of ideas as The Lancet, as New England Journal of Medicine, and other peer-reviewed journals. And this quote from the MIT, David Rand, says that, and I believe this is true, that on social media, people are focused on how much their friends and followers are going to like their posts, the amount of positive social reinforcement they're going to get, rather than their accuracy. And so the issue of information spreading by these massive multinational corporations, Facebook, Twitter, and Instagram, and you can see, and I'm going to discuss the power of these entities and whether or not they have supplanted the influence of the conventional journals that as physicians we've come to rely on, but they have considerably influenced people's understanding of facts. This slide suggests that information in the COVID era is not just about facts, but opinions that become alternate facts. And we have become so polarized in our view of the world and information that partisan differences can define how people look at issues about COVID. And so this is a study from the Franklin Templeton Gallup Economics of Recovery study that took place between September 4th to September 13th, 2020. And it shows partisan differences in COVID transmissions and how death compared to other causes. The orange bars, the question, does flu cause more death than COVID? And if you are a Democrat, you believe that, 13% of people believe that. If you're a Republican, 41% just about believe that flu causes more deaths than COVID. When asked the question, do auto accidents cause more deaths? In the blue, 17.3% of Democrats believe that, 39% of Republicans. Can COVID be spread asymptomatically? I'm sorry, COVID is not spread asymptomatically. Only 22% of Democrats believe that, but more than a third of Republicans believe that. We have an interesting phenomenon whereby the perception of this disease has migrated from the conventional approach where scientists mull the issues, do studies, look at information, and then they disseminate it to their peers in a slow, methodical, deliberate fashion. Nowadays, and I have particularly focused on two major countries, and these are the countries that are considered the leaders of the Western democracy. In so many different areas, the opinions related by these leaders have colored or have influenced the perception and the discussion of so many things. For instance, masks, social distancing, and the concept of herd immunity. You may recall in Great Britain, an early report that suggested that the approach to COVID should be to let as many people get infected and recover so that you could reach herd immunity and not have the problem that was impacting many different countries. What we found was that this approach was a dangerous approach. This was brought into the spotlight when the most decorated public health physician started off with a close relationship with the President of the United States, and then quickly became a pariah. This quote from the Lancet, and I'll read it for you. How can we follow the science when scientists haven't the foggiest? Big mouth scientists losing trust of ministers. Headlines such as these are increasingly common in UK newspapers. Scientists are no longer seen as providing impartial, independent advice to government. They are seen as being responsible for crashing economies, driving up unemployment, and ruining livelihoods. Chris Whitty, England's chief medical officer, and Patrick Vallance, the chief scientific advisor, have received the sharpest criticism. But attacks are now spreading to members of the scientific committees that advise government. They stand accused of leaking documents to journalists, promoting their own personal views, and collaborating with opposition political parties. The argument is that if a scientist is a member of a group advising ministers, they have chosen to be part of the government team and must abide by a rule of collective responsibility. The breakdown of trust between scientists and politicians is so great that senior figures in public health are being blocked from speaking to reporters, even on subjects unrelated to COVID-19. What have we become when the views of a scientist has to be considered through the looking glass of the politician? Face masks, who would have thunk that this would be a controversial issue? And yet, they have become the basis of tremendous controversy and polarization. Indeed, if we go back to the initial Western response, face masks worn by people was something that only the Asians did. And the initial Western response was that face masks were not necessary. Then there was an about face, and that about face added to the speculation that perhaps there was no need for face masks. Indeed, some of the comments made by the scientific community and the CDC and other leadership bodies suggested that cloth masks were all that people needed if they were to wear a mask. But that directive was based on a need to keep N95 and surgical masks for first-line providers. And so it has created a significant amount of doubt in the minds of individuals all around the world. And how that has played out is you have groups of people that wear masks, groups of people that don't wear masks unless they are mandated to wear masks. And now as we have the variant COVID-19 viruses, the mask story has come right back, as the recommendation is that not only should you wear one layer of mask, but multiple layers of masks, and perhaps several masks at the same time. But how can you do that if there's no supply of masks to be accessed? And as the world has reached this 100 million mark and 2 million deaths, will there be masks for people to wear outside of the first world? There was an interesting, I just want to speak to this issue because of the issue of politics. The US election of 2020, was very much about COVID and the response to COVID. Whether those in the audience agree with that or not, that remains my opinion. The president, the then president of the United States, despite being infected with COVID, took a position that COVID was not real, that it was a passing entity that would go away when the weather got warm, that there would soon be a vaccine to solve it, that people really didn't get that ill, even as his country racked up the greatest number of cases in the world, accounting for some 20, almost 25% of the cases in the world, and some 400,000 deaths to date, on the way to 500,000 deaths. So the question of the impact of COVID-19 on the direction of the United States, I put it to you that COVID-19 became the biggest political issue of the 21st century. It is indeed the single greatest issue of our time. And in every single country, including the Bahamas, it has defined our daily lives. It has defined our national expenditure, and it has changed the way we live. There's been a seminal article published in a blog by the World Bank, written by Blake and Wadwa. And in it, they note that in the last 12 months, some 88 to 115 million people have been pulled into extreme poverty. And many of the new poor are likely to be engaged in the informal sector. That we saw the fastest, steepest economic downturn in 30 years, pulling many countries into debt distress from which they may never emerge. That one half of all the companies in the world, are either in arrears now or will be in arrears very shortly. That we have between 1.2 and 1.5 billion newly unemployed out of 8 billion people in the world. and as many as 132 million people now newly undernourished. As I get close to wrapping up, the issue of vaccines has been all about conspiracy theories, about politics, about social media, and not just an issue to be discussed among medical colleagues and others. Some say that vaccines are good. Some say that vaccines are not good. Some say vaccines save lives. Some say vaccines kill. We have already had the discussion that vaccines may have little particles, and I don't believe this at all. Please, I'm discussing one of the conspiracy theories, that it is a way to inject particles into the human body. But the consequence of this controversy is that despite the availability of vaccines, that as many as 40% of individuals, and particularly Black and brown persons, do not and will not accept any of the new vaccines, even if they were available. The availability of vaccines is certainly outside of the G20, not a guarantee at this time. And even in Europe now, there are shortages of the AstraZeneca vaccine because of the challenges of production, distribution, etc. What we know about vaccines is different than what people are being told about vaccines. And so around the world, all of the politicians are saying that vaccines will save us. Even though what we believe we know is that vaccines, at least the Pfizer, Moderna, and AstraZeneca vaccines, have been studied not to stop infection, but to stop people that are infected from dying or getting very ill. And as a matter of fact, it is not clear that persons who are vaccinated, that they will not also be able to transmit COVID-19 infections. As a matter of fact, people that are vaccinated possibly can transmit COVID-19. Vaccines have not been tested adequately in persons 16 or under. And just today, Germany has said that the AstraZeneca vaccine should not be used in people over 65. This debate is playing out in the media, it's playing out on social media, it's playing out in peer-reviewed journals, and it's being discussed. Now, this final slide I show because there has been a bias in the world, created in part because of the perception that this is a Chinese virus. It is not a perception that I hold, but it is something that has been promulgated in a very demeaning, derogatory way, and it has now made its way. And the question is this news? Or is it just another example of biased reporting? I will leave this, which was just published yesterday, for those of you to consider. What has happened, however, is that certainly Facebook, Instagram, Snapchat, Twitter have now supplanted the usual methods of distribution of information. And they have become so powerful that arguably they have been able, by shutting down Twitter accounts, Instagram accounts, etc., to control people even as powerful as presidents and other world leaders. Now, ladies and gentlemen, I've been deliberately controversial in this presentation. I don't believe that I was supposed to do otherwise, and that's why Dr. Roberts gave me this very, very broad topic to cover. Let me conclude by saying that we have not been here in 100 years. Where we are headed right now is uncharted, shark-infested waters. Science, politics, social media, conspiracy have come together in a perfect storm. So on any given day, you don't know what information is going to come, what is fact, what is fiction. And I would suggest to all of you to read all of it with a very, very high-level filter, to consider the source of the information, to believe, but to follow Ronald Reagan when he said, trust, but verify. I had the privilege of serving as the Minister of Health during the early days of the COVID pandemic in the Bahamas. And I started doing a lot of reading about this very early on, and I continue to do so. I probably read between 30 and 60 articles a day on COVID, no exaggeration. I can tell you I'm still lost. And I have listened to the presentations for 3 weeks now, and I want to commend all of the presenters who have done an incredible job in making COVID a little bit clearer. I want to thank the organizers of this event for the privilege of the floor, and I would be happy to answer any questions, and I hope, Dr. Roberts, that I've stayed on time. Thank you very much.
I think I really want to thank all the presenters. Your talk was most thought-provoking. Just what I thought it would be. You read me correctly. You know, you read me correctly, yeah, and delivered most eloquently.
Robin, I'd like to ask a question.
Yes, Dr. McNeil.
So first, I'd like to congratulate Dwayne on doing an excellent job. What he did for me was highlight the challenges of medicine today, meaning that the university has to address how, in educating medical students, to address the issues of fake news, the challenges to the messages that we're trying to get to patients. And Dr. Sanj, you did a great job in bringing that out. So we need to see some curriculum changes that address communication in an extreme way. My personal view is that these ways of thinking were always there, but the social media has brought them to the surface. And now in medicine, we know what we have to deal with. So originally, we had statistics where someone would say something like, we had 55 criminal cases one year and 52 criminal cases another year, so that was a change. And then statistics showed how they may actually have been the same. So now we have the actual information, where we have information that is a blend of untruths. And in order to practice good medicine, we need to figure out how to get our messages across. Dwayne, congratulations, great job.
Thank you.
What was the reason given for the AstraZeneca vaccine being singled out as not to be recommended to persons 65 years and over?
Very good question. Certainly, that was the German regulators And their reason was that the basic data provided by AstraZeneca did not adequately demonstrate efficacy in persons 65 years and older. There was a rebuttal published just today that debunked that view. And so certainly in the UK, they will use the AstraZeneca vaccine, claiming that their data or their review of the data suggests that the vaccine is efficacious, and they will use it. But we have two countries that have diametrically opposite views. And so it'll be interesting to see how this thing plays out.
And herein lies the science. You know, we've seen this continuously throughout medicine, where you have the scientific basis, and at the end of the day, the truth always wins out. Thank you all for participating. It's been a great 3 weeks. All the presenters have been, I think, excellent in the research they've done and the way in which they presented it. And I hope that you have all, you all would feel that you have truly been enriched from a knowledge base, but more importantly, from the community that has spread during this event. I want to remind you that all these talks will be available on our Sunshine Learner platform, as well as they will be on our library platform as well. So good night and God bless.